Okay, so we're all set now, right? Okay, assalamu alaikum everyone. My name is Yousef Alghamdi and I'm a third year medical student. And inshallah, we'll be going over some physiology practice questions for the cardiovascular system. With me is,
Hi guys, I'm Baan. I'm also a third year medical student, and yeah, we're gonna do some cardiovascular physiology questions. I hope this is going to be helpful. We try to focus on very high yield topics and questions that they will most likely get you in the exam. So try to solve with us. Don't stay like passive. Read the question and solve with us. And if you have anything that you don't understand, please stop us at any time and ask us any question that you want.
and please don't be afraid to make a mistake. Yani, we're students like you, and the best way to learn is to make mistakes. I always like making a mistake because after I make a mistake, I will inshallah not forget this mistake that I made. So
This is the
answer
time to make mistakes. Yeah.
exactly. Answer even if you're 0% sure. Okay. Okay. Bismillah. So these are the lectures that you guys took for cardio, and inshallah these are the questions we collected. Okay. So the first question: which of the following structures will have the slowest rate of conduction of the cardiac action potential? Okay, I'll tell you there are some answers. Okay, C, C, C. Okay, mashallah, very good. Yes, the answer is C. Would anyone like me to explain? I think one of the things that you guys didn't like last time is that we didn't explain even if the question was answered by everyone. So I'll just kind of go through it quickly. The AV bundle or the AV bundle is just the slowest because there's a gap because of the conductance, right, of the potassium. That's why we have an AV node delay on an ECG in the PR interval. Come on. Okay, next question is Baan's.
Okay, so a 60-year-old woman has a resting heart rate of 70 beats per minute. Arterial pressure is 130/85, and body temperature is normal. Her pressure volume diagram of the left ventricle is shown above or to the right. Okay, I'm gonna have three questions on the same diagram. So the first question is, what is her cardiac output in millimeters per minute? Okay. Okay, so two people answered E. You guys are correct, mashallah. Cardiac output, can you switch the next to the answer slide, please? Yeah, someone, Yasser said EDV minus ESV multiplied by heart rate. That is the correct formula to use. EDV minus ESV is the same as stroke volume. So stroke volume multiplied by heart rate equals cardiac output. I also added another principle or another equation that was mentioned in your lecture. I prefer, of course, everyone prefers the easy one, but يعني, it was mentioned in your lecture, so please memorize the other one, which is the Fick principle, oxygen consumption or VO2 over arterial O2 minus venous O2. It's not that hard. It's just a lot of words can confuse you, so just put symbols and you'll remember it faster. Does anyone have any questions? It's just simple math. Okay, next question.
Okay, so the next question
It's
is
still mine because there are like two more
okay.
parts. Yeah.
Okay.
Okay, so same diagram, same scenario. When does the second heart sound occur in the ventricular pressure volume relationship? Okay, whoever said A, you guys are correct. It's at point D. Let me see if I can annotate. Okay, so this right here is the stroke volume. Okay, let me change the color. The color is ugly. Okay, here from D to A, this is isovolumetric relaxation. It means that the heart is relaxing without any change in volume. Iso means same, okay? This is isovolumetric relaxation. We start from here, from A to B, then B to C, then from C to D. So the cycle is going like that, okay? From A to B is ventricular filling. This is when the ventricle is relaxing and it's getting filled by blood from the atria. That's why the slope is, there is a slight change in pressure, of course, because the ventricle is getting filled with volume. So there is a slight pressure change, but the drastic change is going to happen in the volume right here, the x-axis, okay? So from A to B, we have ventricular filling. So what type of valve opens at point A? To allow
Mitral
blood,
valve.
yes, to allow the blood to go from atria to the ventricles, the AV valves, the tricuspid and the mitral, should allow blood to go from the atria to the ventricle. So they should open at point A, okay? From point A to point B, we said ventricular filling. And then from point B to point C, it's the exact same thing as D and A, but it's isovolumetric contraction. No change in volume, but we have contraction, like small contraction. Why does the heart do this? The heart has to generate a force to push against the pressure that is found in the aorta. You have to generate a bigger force in order first to open the valve and to allow blood to rush into the aorta. Okay? So the generation of that amount of force, of course, depends on the peripheral resistance, but the generation of that amount of force needs a lot of contraction. So the heart is going to contract slowly in the beginning, and then it's going to contract very fast to push blood out. So the isovolumetric contraction is the slow contraction in the beginning. It's just a buildup of pressure and force. And then C to D is ejection, okay? This is when the blood is rushing out. Here is where the aortic and pulmonary valves open. Of course, we need to eject the blood from the ventricles into the pulmonary arteries and into the aorta. So in these valves open in order for the blood to rush out. And as the question we just answered, point D is when the pulmonary and aortic valves close, and that produces the second heart sound. Is this all understood by everyone? It's an important high-yield concept in CVP. Okay. Yasser said, when does atrial contraction occur? When do you think it occurs? And we said A to B is, where is the pen? Okay, we said A to B is ventricular filling. That means the atria is filling the ventricle with blood. Doesn't it have to contract in order to do that? So atrial contraction is from A to B in order to push blood from the atria to the ventricle. Do you understand that?
I think I put one of the questions where it explains specifically where each event happens, because filling is 3 parts. So we'll get to that inshallah, okay?
Okay. I hope this is understood by everyone. Let's go to the third question, please. Okay. When does the third heart sound occur in the ventricular pressure volume relationship? Okay, B. Yes, between point A and point B. Okay, so does anyone know what S3 is?
Rapid ventricular filling sound.
Yes, exactly. So when the ventricle is a little bit stiff and it has blood in it, okay, the rush of new blood from the atria to the ventricle is going to create a sound like like that. When you already have a lot of fluid in the ventricle and the new blood is coming in, like that. That's S3. And that happens when the ventricle is filling, so from point A to point B. Is that understood by everyone? Okay, I hope so. Okay, what is her ventricular ejection fraction? Same scenario, same diagram. Mashallah, you guys are very good at math. Yes, it is D, 67%, because the ejection fraction, what is it called? Equation, it's SV or stroke volume over the end diastolic volume. Can you go to the next slide, please? Yes, this is the equation you should use. And this is pretty simple math. I didn't find any other equation for ejection fraction. This is the only one I think you have to know. There is an entire slide full of equations in Dr. Simon's lecture. I think hemodynamics one. One of the first couple of lectures, couple of slides, sorry, is a slide full of equations, and they said under the slide that you have to memorize all of them, and there isn't any equation sheet that's gonna be given to you in the in the exam. So sorry for that, by the way, but yeah, that's it.
Okay. Okay, so the next question is mine. If the Purkinje fibers situated distal to the atrioventricular junction become the pacemaker of the heart, what's the expected heart rate? Okay, so two people said A. Asma said A. Sidra said A. Okay, yeah, you guys are right. Yeah. So anytime the pacemaker of the heart changes, the specific part that becomes the pacemaker has a usual specific heart rate. It can become higher than normal for that pacemaker and can become lower than normal for that pacemaker as well. But on average, if the Purkinje fibers are the pacemaker of the heart, then it's between 15 and 40. So 30 here. Okay.
Okay, which of the following events is associated with the first heart sound? Okay, you guys are correct. It is E, closing of the AV valves. This is the first heart sound. The second heart sound, as we just said, it's the closing of the aortic and pulmonary valves.
Okay. Which condition at the AV node will cause a decrease in heart rate? So if you were listening in the first question, so I said this. I kind of said this in the first question. I mentioned it. Okay, some people said D. D, D. Aisha said D. Okay, so the answer is D, yes, because of the increased potassium permeability. So if potassium is permeable, then it will leave the cell, right? And if it leaves the cell, then it becomes more negative or less polarized. I mean, more polarized. So if it's more negative, then it will decrease the heart rate, right? Okay, really good. Inshallah.
Okay. Which of the following events occurs at the end of the period of ventricular ejection? Remember the diagram I explained on? Yes, Yasser and Saad, you guys are correct. Pulmonary valve closes along with aortic valve. That happens at the end of ejection fraction. Not ejection fraction, well, ejection, ventricular ejection.
Okay, really good, inshallah. You guys are good. I don't even know why we're doing this session. Okay, next question. So, which of the following cells or structures require calcium influx for cell membrane depolarization at the threshold potential? Okay, Saad said A, Yasser said A, Asma said A. Okay, yeah, خلاص, mashallah, you guys are good. A lot of questions about the AV node, huh? Okay, yeah, the answer is A. So the question said, which of the following structures require calcium influx for cell membrane depolarization? The cardiac ventricular muscle cells don't. And nerve cells, not necessarily calcium, right? And the presynaptic terminals, they just need an electrical potential, right? And skeletal muscle cells can be most likely sodium. So the answer here would be AV nodal cells. MashaAllah. Okay, next question.
Okay. In which of the following disorders would left ventricular hypertrophy normally occur? You can solve this by excluding some stuff that doesn't make any sense, that has nothing to do with the left ventricle. Wink, wink. Okay. Saad and Yasser, Aisha also said E. That is correct. Aortic stenosis. Does anyone know why?
Can I explain?
Of course.
Aortic stenosis means narrowing of the valve, aortic valve. So the left ventricular, in order to eject, need to be like more pressure or more force should be applied. Due to that, the left ventricle hypertrophies.
Yes, that is amazing. Thank you.
Most welcome.
Blocking blood from going
Also,
to aorta, causing expansion of left ventricle, increase afterload. That is all correct.
yes, I was gonna say that, yes. Very
Okay,
good explanations as well.
on that topic, increased afterload. Does anyone know the difference between preload and afterload? Okay, let me explain it briefly. So preload is the amount of blood in the ventricle before contraction that makes the heart walls stretch.
Yes.
Okay, so
Someone on the
preload is
chat
EDV.
said,
Yes,
yes.
it is EDV. Afterload is the amount of force. See the difference? Preload is the amount of volume or amount of blood, and afterload is the amount of force that the heart has to generate in order to pump blood against the resistance. The resistance in the arteries. مثلا, let's say someone has
Okay.
hypertension. Hypertension means an increase in pressure in the arteries. Okay? That could be due to blockage, atherosclerosis, or just vasoconstriction. That will increase the resistance in the arteries. An increase in resistance in peripheral arteries means that the heart has to pump even harder in order to counteract that resistance. You have to push against something. If the arteries do not have resistance at all, the heart is not going to work. Because the motivation for the heart, let's say motivation, what motivates it is peripheral resistance. If there is no peripheral resistance, what does the heart have to push against? Nothing.
Nothing to push against. The blood will just move on its own.
Yeah.
Another way you can think of afterload is if there's increase in pressure, against the heart, then less blood will be able to move, right? So there's more being left over after load. That's how I remember it.
Does
Okay.
everyone understand the difference between preload and afterload?
I hope so. Yes, Yasser said that it is EDV, and I think we said it was right.
Yeah.
Okay, we'll move on.
Okay.
So the answer was E. Okay. So this next question is mine. I also kind of mentioned this when I was talking about the first question. So inshallah this would be easy for you guys to answer. The cell-to-cell conduction of a wave of depolarization through the AV nodal cells of the heart occurs during which segment or an interval of the ECG? Okay, those of you saying 2, what is the name of this interval?
PR interval.
PR interval, yes. So from the beginning of the P to the beginning of the R, right? Here, the beginning of the P to the beginning of the R. Yeah, so 2. So B is the answer. Very good, mashallah. Okay, good. It's good that you have a good grasp on the normal ECG. Okay, that's good. So next question.
Okay. Which of the following is associated with the second heart sound? We already mentioned this, and I put a lot of questions for this because it is a high yield concept. Yes, it is C, closing of the pulmonary valves.
Yes, I said C in Spanish.
Yeah.
Sorry. Okay. Is there anything else you need to explain here?
No, I already explained this before. So I
Right.
just brought one more question to make sure
Refreshing.
everyone has a concept خاص.
Okay, here we go. Leads. My favorite. So which of the following electrocardiographic leads will produce a positive, so upward net QRS wave deflection? Okay, wait. Bismillah, let me finish the question. If a wave of depolarization is moving through the heart as depicted by the arrow. Okay, mashallah, some of you said it right. Okay, can someone tell me what the inferior leads are? What are the inferior leads? That would be the most perfect answer here. It's not, and not all of them are.
2 AVF and 3.
Yeah, 2, 3 AVF are the inferior leads. Mashallah, very good. Yeah, so the answer here is D. 2 AVF, V4, and V5. So as you can see, the arrows. Okay, so look at the heart from behind. Okay, this is how I'm imagining it. It's moving like this, right? So down and towards the left. So lead 2 is like this, right? It would be the most positive because it's parallel to it. Lead 3 is also in the same direction. It would be very positive because it's in the same direction. AVF is towards the foot also, right? So it's also down, so it will also be positive. V4 and 5 are on the left and lower than the other precordial leads, right? So they will be more positive than the other leads. There was something I wanted to say, but I forgot. If I remember, I think there are other questions about leads. Inshallah, I'll say it. But yes, very, very good. The answer.
Also, guys, this is why we use, I don't know if you guys saw an ECG paper from the hospital before.
Yes.
There's always a strip
Rhythm
for only
strip.
lead 2. Only lead 2. Why? Because it's the closest one to how the electric wave moves through the heart.
Exactly.
Yeah.
Oh, I remembered what I was going to say. Yes. So lead 2 would be parallel to it, right? If something is perpendicular to it, what would it be? So what would lead 1 be? Would it be positive, negative, isoelectric? Isoelectric, yes. Zero deflection because it's perpendicular. Yes, mashallah, very good. If it's perpendicular, So if it's moving like this and lead one is like this, right? So it's perpendicular to it, 0. If it's parallel to it, it would be the most positive. Great. Inshallah, mashallah. Inshallah, third year you guys will do really well because it's mostly just this for the at least first 2 weeks. And I honestly did not understand this in first year. Okay, inshallah. Yalla, next.
Okay. An increase in left atrial pressure is most likely to occur in which of the following heart murmurs? Left atrial pressure. Okay, mashallah, you guys are amazing.
Yeah.
Mitral regurgitation. That is amazing. Regurgitation means as the atria is pushing blood to the ventricles, some of it leaks back. Yes,
Yes.
leaky. Some of it goes back. So more volume than normal in the atria is going to increase its pressure.
Yes. Another word for regurg is insufficiency. So if they say mitral insufficiency, then they mean regurg, okay? And you know how they do in exams, they might try to confuse you. So just keep that in mind, okay? Okay, so yeah, see, inshallah. Done. Okay. So if you are a third year student, you would look at this and you would immediately know what's wrong. Let's hope you guys do too. During a semi-annual exam, the ECG recording of a trained athlete reveals the cardiac arrhythmia shown in the following trace. The abnormality seen in this lead 2 trace is due to a change in which of the following electrical events of the heart? Okay, yes, a process. Don't worry, man. Why my bad? It's a question. No need to apologize. Yes, it is atrioventricular conduction. So what does this guy have? Can anyone diagnose?
This would be first degree heart block.
Yes. No, not third degree. It's
Nah, it's
prolonged
first.
PR.
Nah,
First, he
it's
said
first.
first.
Yeah, no. Someone on the chat said third degree. Yeah, you're right. Yes, yes. It's first degree AV block. So third degree is when the P waves and the QRS are irrespective of each other, right? So the P wave will go on its own, the QRS will go on its own. You'll have multiple P waves before QRSs. All right, yes. I think you. Okay, let me go through all of them. Okay, first degree is just prolongation, simply PR prolonged. That's it. First degree AV block. Hello. Second degree AV block, we have 2 types: Mobitz 1, Mobitz 2, or type 1, type 2. Second degree type 1, second degree type 2. Second degree type 1 is progressive prolongation with a dropped beat. So it would be prolonged, then more prolonged, then more prolonged, then P with no QRS. Okay, that would be a Mobitz 1 or a second degree type 1. A second degree type 2,
There is no progressive, it's just prolonged. And then there is a drop beat. It doesn't like it's not prolonged then more, and then drop beat. No, it's always prolonged, and then you have a drop beat, like 2 to 3, and then drop beat. And the third degree is just what did you say, Yousef, in the beginning?
No,
third degree?
Mobitz 1 is progressive delay in the electrical conduction, then it's a dropped beat.
Yeah, and Mobitz 2 there's no progressive.
Oh, okay. So Mobitz 2 is without progressive delay, yeah.
Yeah.
المهم انه Mobitz 2 and third degree are indications for a pacemaker. I don't think you need to know this, but yeah, it's good to know. Okay. Is that clear for everyone? It left on my phone. Wait. Okay, so we'll move on. If it's not clear, we'll come back to it.
Okay, so we have these PV loops. A lot of people asked for abnormal PV loops and valve abnormalities. So can anyone help me with the one on the left? Which one do you think this is? So the one on the left right here, this point, this is end diastolic volume, right? This point over here, the black line is the normal one and the red is the abnormal one, okay? So this point over here, this is EDV. It's way back over here, way back. EDV is less. So in what valve abnormality is EDV way less? Not much volume is going from the atria to the ventricle. Ventricle is not filling enough. When would that happen?
Someone on the chat answered.
Yes.
Yeah.
Yousef, can you remove the box, please?
Oh, okay.
It's an animation, yeah.
Just let me-
You guys are right, mashallah. It is mitral stenosis. Narrowing of the valve, as Aisha said, and that would cause less blood to go from the atria to the ventricle.
Yes.
Okay. So what about the one on the right?
Aortic regurgitation.
Why do you say it's aortic regurgitation? What gave it away?
There is an increase in end diastolic volume, meaning there is like a leak in the aortic valve.
Yes. Amazing, mashallah. So EDV is way a lot. It's too much, too much. Too much blood is remaining in the ventricle. That means the ventricle is not pumping correctly or enough. Or it's pumping correctly and it's leaking back.
Exactly.
So, Yousef, can you remove the box?
Yes. Very
It
good
is aortic
explanation.
regurgitation. Does anyone have any questions on these two? Because sometimes it's really hard to memorize the shape of it. Like Anna Saha, in first year, I used to memorize the shape of it and just answer based on my memorization. You really need to understand how to interpret it.
Yes.
So whatever shape, if you don't remember what it is, you can interpret it. You're like, okay, this is EDV, this is a lot. What could happen? You can like analyze the graph instead of memorizing it. It's so much
Yes.
better.
Don't memorize it, understand it. Until now, the only ones I memorized are maybe like aortic stenosis because it's very like
لا
clear.
لا تقول
Wait, okay. I think I have a question. My
You
bad.
spoiled the question.
But otherwise, I understand, right? I look at the endostolic and systolic volume. My bad. Okay.
Okay, so can anyone help me with the one on the left?
The last one is mitral regurgitation because there is an increase in EDV and a decrease in ESV. And the right one من الجراف نفسه طويل كثير, so it's aortic stenosis.
Yeah.
Okay, amazing. So mitral regurgitation, EDV is way in the back over here. Like there is a lot of volume left in the ventricle. And also ESV, as Yasser said, mashallah, it is very low. This is the normal ESV and this is the abnormal ESV. This happens in mitral regurgitation because some blood is leaking back into the atria. Okay, this is aortic stenosis. This is very high, okay, in the left ventricular pressure. Why? Because as Aisha explained before, inshallah, in aortic stenosis, the ventricle has to generate way more force in order to push blood. So the pressure is going to increase and it's going to be really high. No diagram is the same as aortic stenosis. I honestly memorized this in first year, but now going to third year, I just understood what it means. So it's amazing.
Yeah, go on.
It's amazing that you guys understand it from now. This is gonna be really good for you in third year. Yeah. What were you gonna say?
I was gonna say I think these are the most commonly asked anyway. Mitral regurgitation and aortic stenosis. Okay.
So does everyone understand the PV loops? Is there any confusion?
Inshallah, there isn't.
Inshallah.
Okay. Leads again, my favorite. Okay. Which of the provided images is correctly labeled for the electrode placement and polarity of 3 standard limb leads? Inshallah, this would be very simple, right? Lead 1, 2, 3. Yeah. Yasser and Asma. Correct. Yeah, so usually these questions they'll ask you, like they'll put a million options because they expect you to know it by heart. Okay? So just make sure you understand or know the lead placement, okay? So yeah, B. Lead 1, 2, 3. Good.
A decrease in which of the following tends to increase pulse pressure?
Saad says C.
Aisha and Yasser B. Okay. Can the people who chose B, can
No,
one of
wait.
you please explain why it's B?
I think B was for the previous question. Or am I confused? I don't know.
No, you're confused.
Okay.
Why do you guys think it's B and why do you guys think it's C? Because there are a lot of mixed answers. I want to know your perspective. Okay. So I think it's C because if we decrease atrial compliance, the pressure will be higher.
Arterial compliance.
Okay.
Yeah,
I
okay.
mean, look, the answer is C, but the explanation is not quite correct. A decrease in arterial compliance means vasodilation. Would
No, wait,
a decrease in
no.
compliance?
Yeah, so it's less compliant. Yeah.
Yeah, it's an increase in compliance means vasodilation.
Yes.
A decrease in compliance means it's more stiff. It's more
Yes.
it's less compliant to the blood flow.
Yes. So
Okay.
Saad is right.
Yeah. So it's arterial compliance. Why would arterial compliance a decrease in arterial compliance cause an increase in pulse pressure? You know what pulse pressure? When you the pressure of your peripheral arteries, that's your pulse pressure. And there's also an equation. I think I put it in the next slide. Pulse pressure equals systolic blood pressure minus diastolic blood pressure. Yeah. This is if they ask you for numbers, of course.
So Saad, you're right, okay?
Can you go back to the question? Thank you. So a decrease in arterial compliance means vasodilation, means the artery is able to accommodate more blood. Like let's say 10 millimeters of blood in your artery over here, مثلا, is not the same as 100 milliliters. And these are imaginary numbers. The more volume in the artery, the higher the pressure is going to be there. Okay, so a decrease in arterial compliance or vasodilation will increase pulse pressure. Is that understood by everyone?
Can you say that again?
Okay, so a decrease in arterial compliance, a decrease in compliance. What does that mean?
Constriction.
Constriction. I think I just said dilation.
Yes, exactly. That's why I asked you to say it again.
I'm confused. So decrease in arterial compliance means that the artery is less compliant. Okay, it's stiff. It's not gonna allow as much blood to flow through it.
Yes.
Okay,
so
it's
there will be more
constricting.
pressure.
Yes, there is more pressure in the artery.
If it's more compliant, it's lenient, it lets more blood.
Yeah.
So it's dilated.
Sorry for the confusion, guys. I got confused with you.
It is confusing. It is confusing. It's like a double negative, positive type of thing.
Yeah. I think if you get confused in the exam, just explain it to
Write
yourself.
it down or
Yeah.
write it down on a paper. I like to write things down just so I don't get confused. طيب بسم الله. I didn't really want to get an access question, but I saw that Dr. Simon emphasized on it, and he said that he would ask access. So I don't know why he would, but he's gonna ask it. I don't know. Anyway, 48-year-old male with a history of hypertension.
This would be 0 because lead 1 is the most positive.
Okay, if lead 1 is the most positive, how does that make it 0?
Because the more positive it is, the more closer it is to a specific lead.
So then, why would that make it 0?
It could be either 0 or positive 30, but I probably say it's positive 30 because also lead 2 is positive.
Okay, but there's something you're not looking at.
And the AVF, it's not 0.
Yes, that's why it's 0. That's why it's 0, right? So if it's parallel to lead 1, that's you were on the right track. You just didn't put the right words. It's parallel to lead 1, right? So if it's parallel to lead 1, then AVF would be 0, right? Because it's perpendicular, completely perpendicular to it, right? Because AVF is straight down, right? I think I put a picture for axis here. Oh, yeah. I put this here. It's clear to see if you guys want to look at the ECG. So I didn't put the axis here, but I put it in another slide, I'm sure. Inshallah, I'll explain it there. So yeah, here it says, let me just read the full question. For the past 5 days, especially at night, while lying flat, a 12-lead ECG is ordered and the results are shown. Based on the ECG results, what's the man's approximate QRS electrical axis? So yes, like Yasser very, very, very well said, or he interpreted, mashallah, very quickly, that lead 1 is very positive. So, mashallah, that's very good, yeah, Yasser. That's really, 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 really smart, mashallah. Tabarakallah. So if you look at lead 1 and it's very positive, you would think that it's parallel to it, right? So then you would look at the things that are inferior, 2, 3, ABF. You would look at lead 2 and it's inverted, right? Look at lead 3. Here, lead 2 is inverted, and lead 3, I think, is this one. I just cut it out because I'm a genius. This is 2, this is 3. It's not as positive as it usually is, and this is inverted. While AVF is isoelectric, right? So that means it's perpendicular to AVF. If it's perpendicular to AVF, then it's lead 1, right? Because AVF is straight down. So very good, Yasser, inshallah. Okay, Baan.
Okay. Which of the following parts of the circulation has the highest compliance?
So which one vasodilates the most? Guys, come on.
Yes,
Simple
you guys
question.
are correct, mashallah.
Yeah.
It is C. I think you guys were hesitant. Please don't be. Whatever
Yes.
answer you think is most likely right, just
You're
type it down.
probably right. Yeah, you're probably
Yeah,
right.
your gut feeling is most likely right.
What about the least compliant? They're also called the resistance vessels. It's
I
not in
think
the
I have a
options.
question down.
Arterioles.
Yes, yes, mashallah, arterioles. If you have a question, I'm sorry, I spoiled it.
So the vascular compliance, guys, is proportional to the vascular distentability. The veins are more able to distend more than the arteries. Okay, the arteries are a bit more stiff because they deal with higher pressure and higher blood flow. And you can think of veins. I think that's why they paint it with blue, because veins are like the chill ones. Okay. I think that's why. I don't know. So yeah, does everyone understand this question? why veins are the highest in compliance?
Inshallah, everyone does.
Inshallah.
Okay. Very nice heart picture. Anyway, a 3-year-old boy with a congenital pulmonary artery stenosis. Congenital pulmonary artery stenosis.
This would be E because I spent a lot of time trying to master ECG. Whenever I see right ventricular hypertrophy, it has to be right axis deviation.
Yes, very, very, very good. MashaAllah.
ولو كان right bundle branch block, it would be
Yes.
white cure as حتى.
Yes, mashallah. That's mashallah, mashallah. That's 3rd-year level. Inshallah, you'll do really well, inshallah, in 3rd year. And inshallah, this year, inshallah, ya Rabb. Inshallah, tabarakallah. That's very good, Yousef. Yes. So, has a right ventricular hypertrophy. Which of the following QRS mean electrical axes is most consistent with this diagnosis? Yes, it is E 110, because if it's aortic stenosis, then it would be right, like Yasser said, right ventricular hypertrophy, which means it is a right axis deviation. And the right axis deviation is 110. Yes, here, this is where I put the picture. Okay. So from about 150, I think, to -90 would be a right axis deviation. Or right? To 150, I think. Somewhere around here. Yeah, I think around here is a right axis deviation. And then around here is where would the left axis deviation be? It would be around
left axis deviation would be from -30 to -90.
negative to -90, yeah, around here, right? So I kind of knew, but thank you, Yasser, for confirming that. So from -30 to -90, right? Or the positive?
لا من -30 to -90 had بيكون left axis deviation.
Okay, yeah, left axis deviation, and this is normal from -30 to positive 90. Yes, tamam. And I think you should know, AVL is -30, 0 is 1. That's why you said lead 1 here, right, Yasser, last time?
Yes.
Because you saw it's the most positive. Yeah, okay, that's actually a really good way to think about it too. SubhanAllah, people think about things in different ways. Yeah, okay, that's good. And positive 60 lead 2, AVF, positive 90 straight down, AVF. And that's another way to think about it. If it's straight down, then what's up, and it's isoelectric, then the one that's perpendicular to it is lead 1. I kind of thought of it in a long way, and mashallah, Yasser thought of it quickly. Okay, next.
Okay. In a given arteriolar blood vessel, the pressure is held constant and the radius is decreased. The resultant change in blood flow could also be accomplished by keeping pressure and radius constant and changing which of the following. So if you get a question that is, shwaya complex or has 2 parts, dissect it. So in a given arteriolar blood vessel, the pressure is held constant and the radius is decreased. What would happen if this occurred? Pressure is constant, radius is decreased.
The resistance will increase.
The what?
Resistance will increase in the first part.
Okay. And also the blood flow will decrease, right? Because the radius is small. Not a lot of blood will go through it. So blood flow decreased. Okay. The resultant change in blood flow could also be accomplished by keeping pressure and radius constant and changing which of the following. What in the what do you call it? Options. Which one of the options could be changed that could lead to a decreased blood flow by keeping pressure and radius constant? Yes, E. Amazing, mashallah. Increasing viscosity. So everyone knows what viscosity is, right?
Resistance to flow.
Yes, exactly. So it's like the difference between water and honey. Honey is more viscous.
Someone said, why isn't it D also?
Fluid
'Cause the
density
fluid,
is not the same as viscosity.
Viscosity,
Yeah.
It's not like the fluid is being compressed. It's thicker. It's like an increase in hematocrit, like someone who has polycythemia, for example. I'm not sure if you guys took it in heme though. You might have. Is this
Can you
clear,
explain the
Ty?
polycythemia, because we have this in pulmonary physio, the
Really?
cyanosis part.
Okay, so there's a disease called polycythemia rubra vera. It is characterized by some mutation you don't need to know about. But basically there's an increase in hematocrit. So there's an increase in viscosity. So, you know, when they take out the blood and they show you that there's plasma and there's hematocrit, right? So that hematocrit will be a lot, so the blood will be very thick. So if it's very thick, then there'll be, do you guys know Virchow's triad? The hypercoagulability, stasis, and I always forget the last one. But basically there's a hypercoagulable state because there's a lot of blood, right? A lot of, red compartment of the blood, or
Red
hematocrit.
blood cells. Yeah.
Red blood cells. Tamam? Does that make sense, Aisha?
Yes, thank you.
Okay, we can move on. Okay, I'll finish this one. Why isn't it clicking? Okay. So this is okay. A patient presents with a complaint of a racing heart and lightheadedness. The symptoms come and go for the last 30 to 60 minutes. The patient experiences such an episode while wearing a 24-hour heart monitor, which leads to the diagnosis of AFib. Which of the following ECG strips belongs to the patient? So what I saw is that you guys really need to know the arrhythmias. So which of the following is atrial fibrillation and why?
It would be C because there's no visible P wave.
Okay, try again, Yasser. I can see P waves in C. C, would you like me to tell you what C is?
C, I think C would be third degree heart block. فلكان D.
No. C is a flutter, I believe.
C is atrial flutter.
Yes, sawtooth appearance. If it looks like a sawtooth, then it's an atrial flutter. You don't have to think about it. You want me to tell you the best way to tell what's atrial fibrillation? You don't even have to look at P waves, nothing. All you have to do is look at the rhythm. If it is irregular, it is atrial fibrillation. Okay? Then you look at the P waves. You don't see P waves, خلاص, confirmed. So look at D here.
D.
Is the rhythm regular?
No.
Is it regularly irregular?
That's irregularly irregular.
It's irregularly irregular because you can't tell what's coming next, right? You can't tell when the next QRS is going to be. So this would be atrial fibrillation, okay? Okay, what about E?
E.
It's labeled.
E would be wait, then for E.
I'll give you a hint.
Ventricular bradycardia.
So 1, 2, 3, 4. I don't think he's bradycardiac. Maybe a little bit, but what I can see here is there's a premature beat. So there's most of them have a P wave and they're all fine, all normal, PQRST, PQRST, except this one. This one has no P wave, only on its own, right? So this one is a premature beat. What about this one? What about F?
Ventricular fibrillation.
Okay, I understand why you would say VFib, but this is to me, this looks like VTAC. It's not VTAC though. According to the question, this is ventricular flutter, but this is ventricular fibrillation. Ventricular fibrillation is very, very, very clear because how I think of it is a child is holding a pen and is going like this. It's so messy. VFib is messy. This is kind of like someone's actually trying to make it look proper. So this is V flutter. To me, it looks like VTAC, but I think VTAC, the QRS would be wider. So this is a V flutter, and this is VFib. Don't worry. I don't understand why they want you to know arrhythmias at this stage, but
we only have we do not have ventricular tachycardia بس نحن عندنا sinus tachycardia و bradycardia.
okay. So
الventricular
I saw flutter and fibrillation in your slides though. So maybe keep that in mind, okay?
yeah, تمام.
AFib is very, very easy to know. Irregularly irregular, it's AFib, okay? Do you guys want me to explain the rest? Well, no need. I think this one's no need. A and E, you don't even need to know. Think about them. They're premature beats. B is SVT. Did you guys take supraventricular tachycardia?
No.
No.
Okay, خلاص, then forget about it. So just know D is AFib, okay? And you didn't take VFib, I guess. Just if you want to know it, you can. But
أخذنا ventricular fibrillation.
okay, so this is VFib. It's literally like a child scribbled on the paper. Okay, VFib. And for virtuous triad, the third one was endothelial damage. I remember. Anyway, yeah. Oh, I think one of these is a heart block. Oh yeah, these two are heart blocks. But you guys want me to explain heart blocks again? That's why I put the slide here. This is from Dr. Simon's slides. Would you guys like me to? We can move on. Or I can explain heart blocks or cardiogenic shock, basically. Okay, khas. Good. If anyone doesn't understand, please let me know. According to Simon, this is important, okay? I always see torsade the point. What is it? Torsade is when we have. Oh, I don't think you guys need to know torsade, do you? Here,
We
this
took
is
it in
torsade.
first year when it was Dr.
I
Abdul
remember
Jabbar.
we did take it. It's multifocal after VFib. It's when you get ventricular fibrillation, that's multifocal. So you have unifocal and you have multifocal. Unifocal means it's in one direction, multifocal means it's in multiple directions, right? So if you have multiple direction, then it's VFib or VTAC. I'm not sure. I think VTAC. And then it becomes
It's
progressive.
it's VTAC. في
VTAC. It
الريجولر
progresses.
torsadis epipontis is irregular.
Yes, torsade de pointe is basically multifocal ventricular tachycardia. That's when you get ventricular tachycardia and it progresses into torsade de pointe. So it's like ventricular tachycardia, but on another level. It looks like. So don't put these together. This is how it looks like to me. It looks like a crescendo decrescendo. It has nothing to do with crescendo decrescendo. Okay, it just looks like it. A crescendo decrescendo is an aortic stenosis. Okay. It's a sound that you hear from auscultation. It just looks like someone is raising the volume, then decreasing the volume. I don't have a picture for torsade, but I'll show you one at the end of the PowerPoint, inshallah. Okay. Actually, here, look. I don't wait. Oh, my thing is blurred. Okay. Can you see? Yeah, look.
Yeah.
It looks like someone is raising the volume, then decreasing it. Kind of looks like a up, down. That's torsade. Okay. I hope that answers your question.
Okay. The following illustration shows an interconnected capillary bed. If the resistances R1 through R6 are equal in magnitude and flow is constant, which statement about total resistance in region A and region B is correct? Yes, mashallah, amazing. It is B. A is greater than B. Does anyone know why? Okay.
In A, like the series resistance, we add up. In parallel,
Yes.
we 1 divided by R1 plus
Yes,
1.
exactly. So the equation for resistance in series is different than the equation for resistance in parallel. This is literally the easiest concept in CVP. So can you go to the next slide, please, Yousef? So what I highlighted is the explanation. In series, R total, you just add up, like Aisha said, R1 plus R2 plus R3. But if it's parallel, we put 1 over R1 plus 1 over R2 plus 1 over R3, 1 over R million. So the ones in series are always going to be bigger than the ones in parallel.
Okay, very good. Can we move on? Okay, Wigger's diagram. 50-year-old man visits his physician for an annual exam. He complains of mild breathlessness on exertion. Upon cardiac auscultation, the physician detects an S3 sound. At which point on the cardiac cycle does the S3 sound occur? So Yasser says U, Saad says F, which is U. Okay. Okay. Does anyone have any other answer? I'm not saying you guys are wrong. Okay, yeah, you guys are right. So it would be around here, right? S3. So the sounds are in order, by the way. S1, 2, 3, and then before 1 is 4. So the S3 heart sound is produced by conditions that have chronically high preload, like which just like concentric hypertrophy. But I'm not sure you guys need to know concentric hypertrophy. Yeah, so F or U. Okay.
Okay. A patient at rest is given a drug that reduces venous compliance, but has no other cardiac or vascular effects. What effect will this drug have on venous return and venous blood capacity? Yes, you guys are correct. It is E. So reducing venous compliance, that means vasoconstriction of veins. It's less compliant to accommodate more blood. So vasoconstriction in arteries means like almost opposite to what vasoconstriction in veins mean. So vasoconstriction in veins means, imagine the vein is like this and you're constricting, you're pumping the blood back to the heart more efficiently. Okay, so imagine the veins as a pump. You're constricting, you're pumping, constricting, pumping, like that. That's how it happens in, for example, your calf. When you're walking, the muscles are contracting and relaxing, contracting and relaxing. They're also pushing on the veins in order to push blood back more efficiently. That's why they tell you to walk on like long flights, right?
Mm-hmm.
So, reducing venous compliance means vasoconstriction of veins. That means increasing the amount of blood that goes back to the heart, i.e. venous return. So venous return will be high, such as in E. And of course, you're decreasing the amount of blood that is pooling in the veins. So the amount of blood in the veins is less.
Yeah.
That's why the answer is E. Venous return is high and venous blood capacity is low. Because you vasoconstricted, the radius is less.
Mm-hmm.
Is that easy enough for everyone? I think it was, mashallah.
Theme test prep, our sponsor for today. Most of the questions are from there.
It's in Guyton Hall.
Guyton, yeah.
Yeah.
Okay. This will take a minute. We're on this PV loop. Okay, I'll take this part by part, okay? So we're on this PV loop is rapid ventricular ejection. Rapid ejection.
Rapid ejection is from C to D.
Okay, then what about slow ventricular ejection?
Also from C to D, but it's after rapid.
Okay, if I told you pinpoint where is rapid ejection, what would you say?
5 and 6 respectively. Like if we make it on the left diagram,
Let's look here. Let's look
ventricular.
here. Let's look here. Let's look here. Only on the PV loop.
Okay.
But I guess okay, yeah, it's the same thing, right? But here it would be easier. Look here and then correlate to here. So where would be rapid ventricular? Where if I give you options A, B, C, D, where would you put rapid ventricular ejection?
It would be at C.
Yes, at the beginning of the ejection phase, right? It's more rapid, and then it slows down, becomes slow ventricular ejection, which is at D. Tamam?
So,
And Baan very well explained the heart sounds already, but let's go over them again. Where would S1 be?
B.
Yeah,
S2 would be
S2. Say that again, Yasser.
S2 would be at D.
مظبوط. Yeah, S2 would be at D. So S1 would be here, and S2 would be here, right? On the Wiggers. Okay, so this is something that I found in Dr. Simon's slide, and I want to make sure you guys know it. So, right ventricular filling, diastasis, and atrial contraction. طيب, where are they
A to
on
B.
here?
A to
Yes, they're all from A to B, right? But diastasis is specifically around A, right? And sorry, diastasis is in the middle. Right ventricular filling is around A, right after A. Diastasis is in the middle, and atrial contraction is around B. Because you guys know that the filling is in 3 phases, right? There's passive, there's venous, and then there's the contraction of the atrial muscle, right? So when the AV valve opens, the blood that's already in the atria will fall passively into the ventricle, which is the first phase, or the RVF, yeah, rapid ventricular filling, right? And then we have diastasis, which is basically the blood coming from the vein into the ventricle على طول. And then the last one is atrial contraction. So the atria itself, it pushes the last 20% of blood that's left in the atria into the ventricle. تمام? And then you guys know isovolumetric contraction and isovolumetric relaxation. From B to C, contraction. From D to A, relaxation. Is that clear?
Clear.
So
تمام.
think about it this way. Fluids flow from high pressure areas to low pressure areas. So the atria will accommodate a lot of blood until the pressure in the atria is really high, and it's way higher than the ventricle. That's why you have passive filling. It's just flowing. And then when most of the blood has gone into the ventricle, but not all of it, okay, the pressure in the ventricle and the atria are starting to get equal. That's when the atria must contract in order to push the rest of the blood into the ventricle. I think about it this way.
Okay, good. Is that clear, everyone? Hope it is. Here's the answer in case you guys want it.
Okay. A 75-year-old man with no serious health complaints is scheduled for a routine cardiovascular checkup. What is expected for his arterial compliance as compared to a healthy 25-year-old man? And what effect will this have on his arterial pressure and cardiac work? Remember, this guy is 75 years old. What would happen to his arteries when he's old?
Whatever answer you picked, you're probably right. Just say it. Even if you're not right, it's fine. We'll explain. Come on, guys.
Just guess.
Just one answer. Just guess. Okay, Saad says B. Asma says D. Munib says D. Okay, so
Okay.
Baan.
So the answer is B. No, so I changed that last minute.
No,
Even
Saad, you were
me
right.
also. I thought first is B, then I thought like it's D.
See, sometimes you
Uh,
just don't overthink the question.
Don't overthink it,
B,
yes.
why is it B? Okay, B and D have the same answer for change in arterial compliance with age. You guys are correct when it comes to that. With age, as the person ages and gets progressively older, the arteries become less compliant in comparison like to a 25-year-old that is
Yeah.
healthy. Okay? So as the person grows older, their arteries become less compliant. So the compliance would go low. What options would we exclude? C and E. So we have A, B, and D.
Yes.
Okay. Effective compliance change on arterial pressure. The arteries are less compliant. Would the pressure go high or low?
Hi.
It would go high, right? They're less
Yes.
compliant. They're not working with you. Okay.
They're not, yeah.
Yeah.
They're giving you a
So the
hard
pressure
time.
would be higher.
They're giving you more pressure at work.
Yes. So which one of A, B, and E has the arrow going up on the second column? B and D. Okay, we narrowed it down to B and D. Effective compliance change on cardiac work. So the arteries are less compliant. They have more pressure. Remember what I said in the beginning of the lecture? If the arteries have a lot of resistance, that means the heart has to work extra hard to push
Yes.
against that resistance, right?
They're giving you a hard time at work.
Yes.
So you have to work more.
So your cardiac work is going to increase. Your contractility is going to increase. So that leaves us with only B.
I hope this question comes and then you guys remember that it gives you a hard time at work and you remember my face and then you answer.
Is that clear?
Very nice question, Baan. I like this question.
Thanks.
Clear. Does anyone not
I hope
understand?
it's clear to everyone that said D. Because less
Asma,
compliance.
Munib,
Yes,
Aisha.
less compliance means more hard work from your heart.
Yes.
Okay.
Okay,
Alhamdulillah.
good. Okay. More wiggers. Bismillah. طيب. A diagram showing pressure changes of the left atrium, left ventricle, and the aorta during one cardiac cycle is shown. The 7 phases of the cardiac cycle are labeled from 1 to 7 on the diagram. Excuse me. During which phase of the cardiac cycle is the largest volume of blood pumped from the left atrium to the left ventricle? Okay, guys. So, what is phase 2? What is phase 1? What is phase 1? Phase 1 is the atrial contraction. That's only the last 20%, right? So it's not the most. Someone said 6. 6. Yes.
6.
Yes, 6 is the right answer. Yes. So remember, I told you it's 3 phases, right? So you can see the 3 phases very clearly here, right? 6 is the first phase. That's the most amount of blood, okay? And then 7 is diastasis, or I remember it as venous filling. I don't remember. I don't know why. What's his name? Simon says diastasis. So that's the second phase, and then the third phase was atrial contraction, or phase 1, right? And that's only 20% of blood. For Asma said phase 2. Phase 2 is the isovolumetric contraction, okay? So phase 1 is atrial contraction. Phase 2 is isovolumetric contraction. Phase 3 is the rapid ejection, okay? Phase 4 is the slow ejection. Phase 5 is the isovolumetric relaxation, and then we have the filling again. Tamam? I put the explanation on the other slide so you can see it. It's all here.
Just
Phase
remember
1.
what I said. Passive flow of the fluid goes from high pressure areas to low pressure areas until they equal, and then when it equals, atrial contraction must occur in order to push the remaining of the blood. So what happens first is passive.
Yes. Tamam.
Okay, more tables. Most of the exam is going to be a lot of tables like this.
Yeah, they love tables at CVP.
Yeah. So in the systemic
Renal.
circulatory system, as blood flows from arteries to capillaries, what changes occur to the total cross-sectional area of the blood vessels, the velocity of the blood flow, and mean blood pressure? Okay, mashallah, you guys are saying C. That is correct. It is C. The capillaries are the biggest when it comes to total cross-sectional area. Why? Due to the immense amount of branching. They are tiny, right? They are very tiny, but they are branchy as hell. They branch everywhere. So their cross-sectional area, many branches, their cross-sectional area is bigger than the aorta itself. بس الأورطة الحالة. Aorta is alone, but the capillaries have so many branches, branchy, yes. So their total cross-sectional area is high. They're the highest. I can get you a recall question saying what's the highest in total cross-sectional area. Just
We
say
got this
capillaries.
question in our exam.
Yeah. So an increase in total cross-sectional area happens in capillaries. What would happen to velocity of blood flow? The capillaries are really small, really small. Would the blood flow be very high? No, it would rupture. They're very tiny. If you push a lot of blood into it, they're gonna rupture. So velocity will decrease.
There is a lot of blood as a total because we have a lot of capillaries, but not in a single unit.
In the single one, there is not a lot of blood to.
Not much.
Yeah. As diameter decreases, velocity decreases as well. And also mean blood pressure, it also decreased due to the decrease in blood flow. Not a lot of blood is going through the capillaries, so the blood pressure would decrease. Is that clear for everyone?
Yes, it says Sue. Thought I'd share. Okay. So yeah, the answer is Sue. Okay. 22-year-old woman. Sue. 22-year-old woman occasionally faints. Her resting blood pressure is 120/75 and 95/60 after standing up. What does she have? Quickly. What is this called? Okay, we'll move on. Her resting heart rate is 95 beats per minute and 115 beats per minute after standing up. Which of the following physiologic cardiovascular changes most likely causes her abnormal response to postural change? No, guys, no. She has orthostatic hypotension. What is that? Postural hypotension. What is hypotension? How does someone become hypotensive? Yes, A. It's A. It sounds confusing, right? But it's A, because hypotension is decrease in blood volume. That's it.
Yeah, they got up and all their blood pooled to their legs.
Pooled into their legs, yes. So there is less blood to the brain, so they felt lightheaded. Less oxygen.
Also, the baroreceptors sense that there is less blood in the area. Yeah.
So they become tacky. This can happen in many things. For example, people who have anemia, as you guys took in heme, iron deficiency specifically, and people on antihypertensives, things that vasodilate. Okay, does that make sense? Yasir and Aisha?
Yes.
It's
Okay.
clear.
Tamam.
Okay, a cardiac function graph, your favorite. The graph shown depicts two compliance curves for the same vein and measured at different times. Which of the following conditions would change curve 2 to curve 1?
C.
Amazing. Yes, it is C. A change from curve 2 to curve 1, as you can see, the change is drastic. It went really high in the y-axis. The y-axis is volume. That means the vein is accommodating more volume. Which of these will means that the vein is able to accommodate more volume? Reduced venous tone, or more compliance, or vasodilation. All same thing. Is that clear?
I hope that's clear.
Yes.
Okay. Okay. So a 47 shock, let's go. Okay, a 47-year-old woman is transported to the emergency department after fainting at a baseball game. She is conscious but feels dizzy, cold and clammy. Her blood pressure is 82/55. Her pulse is 120 beats per minute, and respiratory rate is 21, so it's slightly elevated. Breaths per minute. Body temperature is normal. She admits to chronic constipation for several months, so she's been doing Valsalva a lot and seeing blood in her feces. Okay. Uh, Physical exam reveals profuse bleeding from the anus and a shock is diagnosed. What type of shock is most associated with these signs and symptoms? So Saad said C, and that is very good. Asma, very nice. Yeah. So she has hypovolemic shock, right? So it's because of less circulating blood volume. So it's insufficient from hemorrhage, from the bleeding, from etc. تمام؟
So if we have reduced blood pressure هذا يعني hypovolemic ولا شو؟ يعني I need
No, hypotension doesn't necessarily mean hypovolemia, but from the clinical aspect of the patient, you can tell, right? So cardiogenic shock would be heart failure, right? So if it's heart failure, then it would be congestive. They'd have edema, stuff like that. Then you would think it's cardiogenic. But if it's hypovolemic, then yes, there would be less blood volume, and they would most likely be hypotensive. Yes. Neurogenic.
Drastic changes in blood pressure do not depict what type of shock it is. It's just يعني it's a supportive
sign.
Sign. Yeah. So what you can diagnose what type of shock from is how much she's bleeding. She's bleeding out from everywhere.
Yeah, guys, I looked at your slides and I didn't see anything about obstructive, but I just wanted to make sure that they didn't explain obstructive shock. Did they? Because I saw a lot of questions and I didn't put them. Did they? Did you guys take DVT PE?
No.
Okay, good. خلاص. So neurogenic would be anything related to nerves, baroreceptors, the brain, whatever, right? And I don't think you need to know distributive either. Okay, tamam. Yasser, is that you? Did you follow me? ركز هنا.
Yeah.
Okay. Okay, so this is my question.
An athlete training for a marathon is suspected to have received illegal erythropoietin injections to increase his red blood cell count. If true, which of the following hemodynamic parameters is expected to be decreased? Everyone knows what erythropoietin is, right? It's a hormone released by your kidney to stimulate erythropoiesis in the bone marrow, increase red blood cell count. He's an athlete, so if he takes erythropoietin and increases his red blood cell count, he would increase his oxygen carrying capacity. Okay, so the answer is C. Because as we explained before, polycythemia would increase blood viscosity. So an increase in viscosity will decrease blood flow.
I think Asma answered this on the chat. She said C.
Yeah.
So yeah, this is again polycythemia. Tamam? So there are positives and then there are negatives to the drug that these athletes take. He'll have more oxygen, but then he'll have thrombosis. Anyway, hypovolemic shock, cardiogenic, and distributive shock due to sepsis, so septic shock, have which of the following abnormally low features in common? Saad says D. Why question mark? Be confident. No, pick one. D or E, pick one. You got this. Trust your gut.
دي
Would you say?
دي لأنه في أديمة صح؟
Yes. So what does that mean? It's
إيه
D, right? No, it's D side, yeah. But what does the edema have to do with it? It's okay, Saad, don't worry.
I think لأنه أديمة is oxygen delivery to the tissue.
Say that again.
الأديمة يعني if there is low oxygen delivery to tissue يصير في أديمة, and as what we've mentioned before, the cardiogenic shock and all of these, they also have edema.
Okay, so what you said is not wrong. It is oxygen delivery to the tissues, but edema just means that the blood isn't leaving the veins properly. So it's kind of pooling in the legs and the lymphatic system isn't draining it well. So there'll be like swelling. There's pitting, non-pitting edema. You'll learn that inshallah. I don't think edema is a very important sign in terms of hypoxia, but for hypoxia, the patient will be blue, cyanotic, and they'll have trouble breathing, stuff like that. You got the answer right, but you used the wrong formula. But yes, it's good thinking. It's good thinking. And Saad, it's okay. There's no problem with making a mistake. Inshallah, you'll remember this in the exam if they ask, what's common between cardiogenic, distributive, and septic. Basically, less oxygen delivery. Tamam? Okay. So basically, all types of shock have in common is that there is an abnormally low oxygen delivery to the tissues. That's why people pass out, right? So in hypovolemic shock, it's because either they have hemorrhage or they're bleeding, right? It's kind of similar to orthostatic hypotension, right? Because the blood leaves and there's less blood going to the brain. In septic shock or stuff like that, the blood is infected, right? There's toxins because of bacteria or stuff like that, so it distributes to everywhere. So the parts of the body that really need oxygen aren't getting enough, like the brain, for example. Usually there would be more blood in the brain and the liver, for example, compared to other organs that you're not really using right now. So shock in general just means oxygen isn't being delivered. Oxygen isn't being delivered properly. Tamam. Okay, good.
Okay, so are you guys okay with taking a break now? Go back to
Would you like a break?
لا تطلع سؤالي.
Okay.
We can take a 10-minute break.
Would you guys like a break, or do you want us to continue and finish earlier? We still have a few, well, not a few, but we still have a lot of questions left. Would you guys like? Can we take a 5-minute break? Pray Asr and stuff?
Yeah, let's get up and stretch شوية.
Okay,
Get a
let's
cup of
take a
coffee.
5-6 minute break. Yeah.
Okay.
Okay. Is everyone back? Just want to make sure everyone's back. Saad, Asma, Sidra. Okay. Bismillah. I believe it's Baan's question.
Okay. So the diameter of a precapillary arteriole is increased in a muscle vascular bed. A decrease in which of the following would be expected? Increase in diameter. What would decrease?
Come on, guys. Straightforward.
So
You got this.
vasodilation. Yes, it is E. Because
صحيح.
vasodilation, you decrease resistance. Yes, you guys are right, inshallah.
Okay. Is there anything not clear about the last question? Okay. A 16-year-old boy involved in a knife fight is transported to the emergency department. A severed artery in his forearm was bleeding profusely, but it's now controlled. Okay? Which of the following cardiovascular parameters would be lower during compensation for the hemorrhage than before the hemorrhage? So during the compensation, it would be lower compared to before the hemorrhage. Okay, Yasser. Does anyone else have an answer? I'm not saying you're wrong, Yasser. Okay, Asma and Sidra say C. Okay, why C? Why do you say C? Good thinking, but why do you say C? During hemorrhage, the hydrostatic pressure would be reduced, right? So then we'd have more fluid reabsorption rather than less. So C is not the answer. But yes, so you're very, very right. It's A. So the blood loss will result in a decrease in the mean arterial pressure, which will reduce the baroreceptor stretch. So the activity of the baroreceptor would be less. Okay? Does that make sense, everyone? Okay. Does that make sense, Asma and Sidra? I hope it does. Okay.
A healthy 28-year-old woman stands up from a supine position. Which of the following sets of cardiovascular changes is most likely to occur? She has postural hypotension. What would happen? Okay.
That's good thinking, yeah, Yasser. Eliminate
Okay, Yasser
options.
said you are correct. The heart rate increases. Okay, that limits our answers to A, B, C, and D. We can eliminate everything else. Okay? So, what happened to the renal blood flow?
Mm,
ولا خلينا من renal blood flow. Let's go to total peripheral resistance. Okay? So, the total peripheral resistance would increase, right?
yeah, I would say so.
Why? Because when she stands, the
Compensates.
blood is pulling down, the baroreceptors are activated, it's going to constrict on the arteries peripherally.
Well,
صح Yousef?
yeah, so they'll less activate, they'll be less stimulated. So they'll think that there's less blood, so they'll constrict.
So total peripheral resistance would be high.
It would be
So
higher,
heart rate
yes.
high and total peripheral resistance would be high. So we eliminated C and D. We only have A and B now.
Another thing you guys should keep in mind, they said most likely to occur. What will happen? Tamam? Okay, so heart rate will go up, like Baan just said, and the TPR would be higher. So what will happen to renal blood flow? If the body thinks that there isn't enough fluid, what will it do in the renal system? Will it excrete urine? Will it urinate, or will it keep the fluid? Keep the fluid, right? So what does that mean, Baan?
So the renal blood flow would be low.
I agree. So people who said B,
Does
very
everyone
good.
agree?
We want blood to go to the brain more than the kidney, so blood flow to the kidney would
Yes.
decrease. That is correct thinking, but the more correct reason that the renal blood flow would decrease is that we want to filter less blood. We don't want more blood to be filtered because we have right now the body thinks it's in hypovolemia, so it doesn't want to get rid of fluid.
It's
So
a
the way that
sympathetic,
kidneys, yeah,
it's a sympathetic system activation reaction. The
yes,
sympathetic
blood flow
system
to the
is
kidney.
activated. What would happen when you're on fight or flight?
Mm.
Would the blood go to your kidneys?
No, because you don't
No,
want
you don't
to
need you don't need
urinate.
to pee right now, right?
No, you don't need to urinate.
You need to run if you're being chased. You need to think. You need to use your brain, and you need your heart to pump blood. So when your sympathetic nervous system is activated, less blood will go to your renal system.
Wallahi, that's why I thought that it was so bad that you guys take cardio before renal. So the way the kidneys work is the blood that goes to the kidneys, part of it is filtered as well as supply the kidneys. طيب, there are blood supply for the kidneys, but when they say renal blood flow, they don't mean the blood supply to the kidneys. They mean the amount of blood that's going to the kidneys to be filtered. It's not the blood supply to the kidneys. That's different. Okay? The blood supply to the kidneys is the blood supply to the kidneys.
Everything
It's
is
not
going to
the renal
have blood
blood flow.
supply. We're not going to stop
Yes.
blood supply to
Yes.
anything. We don't want to kill anything.
Yes.
Everything is going to have blood supply. But when we're talking about the kidney, as Yousef said, it's about filtration. How much is filtered. We don't want to filter a lot because we don't need to urinate right now.
Yeah, we're not talking about the blood supply of the kidneys. Please don't mix these up, okay? I don't know why they're giving you CVP before renal.
We
But,
had CVP before renal.
Yeah, I know, but still, it doesn't make sense either way, does it? Renal and GI are the last systems to be talked about. Sorry,
Yeah.
cardio and GI are the last systems to be talked about, usually.
Mm-hmm. Okay. So does that make sense to everyone? Is it clear?
So decrease renal, so decrease renal blood flow to decrease the excretion of urine. Okay? Valsalva maneuver. I think I have 1 or 2 questions about Valsalva because last year I explained it and they told me he didn't bring any questions about it. Anyway, when the Valsalva maneuver is used as a cardiac function test, the patient is asked to exhale forcibly against a closed glottis. The testing physician monitors the normal physiologic body response to continued strain for about 10 to 25 seconds after the beginning of the test. A rise in which of the following is monitored after the beginning? What's gonna rise? Okay, Saad and Asma, CD, you're absolutely right. Sidra, absolutely right. Very good. So the heart rate will increase. So the strain of the Valsalva maneuver increases the intrathoracic pressure. That will squeeze the compliant vessels and increase central venous pressure and decreased venous return, right? So that will in turn decrease systolic and mean arterial pressure. And if that happens, the heart rate will go up. The baroreceptor reflex outflow, basically. So there'll be reflex tachycardia.
A healthy 25-year-old male medical student has an exercise stress test at a local health club. Which of the following sets of physiological changes is most likely to occur in this man's skeletal muscles during exercise? Remember, he's exercising, his muscles are working.
So they need blood.
Yes. Yeah, Munib, you're right. It
Very
is
good.
G. It is G. So the muscles need more blood, right? Would they have a lot of resistance? No. They'll
They need blood to
vasodilate,
cool
so
them.
arterial resistance is low. So that excludes A, B, C, and D. You only have E, F, G, and H. Okay? Adenosine concentration Does anyone know what adenosine does? Adenosine is a vasodilator, okay? It's released by the cells. Yes, it is a vasodilator, exactly. So as we said before, the muscles need more blood, so they won't constrict, they will dilate. So they will release adenosine in order to locally vasodilate their arteries. So adenosine will be high, right? What options? Okay, so only F and G. We narrowed it to only F and G. This is how you should solve tables in the exam. Okay, exclude. Start with the first column. Which one is right? And then exclude the ones that do not have the first column right. Okay, so we have F and G. Vascular conductance, which also means blood flow, but they might confuse you with that. So vascular conductance is blood flow. We vasodilate in order to increase blood flow. It wouldn't make sense if it's low. Should be high. So the only one that has vascular conductance high is G.
So, very good, Munib.
Does everyone else understand it?
Great. Does anyone need this to be explained? Okay, we'll move on. Okay, Bismillah. 17-year-old girl with orthostatic hypotension presents with complaints of multiple syncopal episodes. Syncope means fainting in case, I guess you guys know, over the past month when standing up. To prevent syncope, which of the following changes to cardiac output, arterial resistance, and venous compliance occur as part of the normal baroreceptor reflex in a healthy person when standing up? So what will happen when which of the following changes cardiac?
Would it C?
Okay, why C? Tell me.
Because first, we could just say that cardiac output is reversely proportional with venous compliance.
Okay.
So this eliminates choices A and F. And since we're standing up, we need more venous return. So we just keep B and C.
Okay, so we need to decrease venous compliance.
Yes.
Yes.
بس again, choices B and C, and since we're standing up, the blood needs to flow even more, like the oxygenated blood, while the resistance begin.
So resistance will what?
Begin.
Okay, you were right the first time actually. It is C, not B. So upon standing up from sitting position, the CVP immediately drops and the blood pools in the extremities, right? This triggers the decrease in the baroreceptor activity, and because of the low blood volume and the pressure in the thorax, this will increase sympathetic output. So this will vasoconstrict, so this will increase arterial resistance. And if we increase sympathetic, you will also increase cardiac output as it has a positive ino and chronotropic effect. And since you're increasing sympathetic, again, you're increasing arterial resistance. That also means you will decrease venous compliance. So basically, this whole question is, what will happen when you have orthostatic hypotension? You will have sympathetic increase, which will increase cardiac output as a chronotropic and inotropic effect. And you will have an increase in arterial resistance as a vasoconstriction. And you will have a decrease in venous compliance as the veins will narrow, or you'll have venoconstriction. Tamam? Is that clear, Yasser?
Yes.
Tamam. Good thinking, Yasser.
Okay. Histamine is infused into the brachial artery. Which of the following sets of microcirculatory changes would be expected in the infused arm? So histamine is a vasodilator which is released by mast cells and basophils. going to vasodilate. Try again, guys. No, it's not D.
Good thinking, but try again.
Vasodilation means that the vessel is going to relax, right? These two are endothelial cells. This is them like contracting, vasoconstriction. If you vasodilate, they'll do this. See, there's a space between them. That means that there is going to be more leakage of stuff that is in the capillary will leak out. That means they'll increase capillary water permeability, right? So any answer that doesn't have an arrow standing up in capillary water permeability column, it's out. Okay, so E, F, G, and H, they're all out. Okay, so Kafu Munib, you are right. It is A. So let me re-explain. Endothelial cells, vasodilation, increased capillary water permeability, more leakage. Okay, so if you have more leakage, that means you're going to increase the capillary filtration rate. Do you guys know the difference between filtration and reabsorption? Reabsorption is taking fluid from the interstitial space into the capillary. Filtration is moving fluid from the capillary into the interstitial space. So filtration means fluid out of the capillary. If you vasodilate and you increase capillary water permeability, that means you're going to increase filtration rate. So capillary water permeability and capillary filtration rate are going to be high. Which options have that high? You have A and D. So B and C excluded. Okay. What about capillary hydrostatic pressure? So the decrease in arterial resistance would also increase capillary hydrostatic pressure. An increase in water permeability and hydrostatic pressure would increase filtration rate. If you have a lot of water, like hydrostatic, I think about it as water. And colloid, I think about it as plasma proteins. Water goes to a place where there is a lot of plasma proteins to dilute it until both areas are equal in amount of water, okay? So if you have a lot of hydrostatic pressure, it's going to leak out to go to the interstitial space. So everything actually would be high. The vessel is dilating more with hydrostatic pressure increase though. I'll tell you why. An increase in permeability, okay? An increase in permeability. If there is no filtration, if there is nothing to come out from the capillary, why would hydrostatic pressure be high? It should be high. Like imagine there is, you got an insect bite, okay? Now we have inflammation. How does this inflammation happens? The antigens from this mosquito bite, for example, okay, they're going to enter your skin and they're going to cause a reaction that will call on white blood cells, like mast cells and basophils. They will release histamine. Histamine will vasodilate the capillary, and the capillary will release its white blood cells into the interstitial fluid. So in order for the white blood cells to move from the capillary into the interstitial space, there should be a lot of hydrostatic pressure. If there is no capillary hydrostatic pressure, nothing will move out.
And another way to explain this is if the cross-sectional area is increased, the velocity will be constant, right? So that will, if the cross-sectional area is increased, the fluid velocity will decrease. And we need to keep that a constant, right? For us to keep it constant, the same flow rate, the fluid must exert more force on the vessel wall. So the hydrostatic pressure needs to increase to keep the same velocity of the fluid as a compensatory mechanism.
Is that clear, Saad?
Okay.
Alhamdulillah. So the answer is A.
Okay, which condition normally accompanies acute unilateral right heart failure? دخلنا في heart failures, which is also known as cardiogenic shock. Okay, guys. Saad A. Everyone else. Sidra. Okay.
A.
Yasser says A. Okay, you guys are right. So do you guys know the difference between right heart and left heart failure?
مش كاميرا أصلا بس شغال مين
Um, yeah, she realized. Okay. Would you guys like me to explain the difference between right and left heart failure and what will happen to, well, should we, if there's another question? Khas, okay. Yeah, A is the right answer. So basically when we have right heart failure, there will be an increase in right atrial pressure. Why? Because when you have right heart failure, there will be congestion into the body, right? So the blood from the body won't be coming back properly because there's an increase in pressure in the right heart. So right heart failure can either be because of a pulmonary issue, which will then be called cor pulmonale, which is right heart failure due to a pulmonary مثلا embolism or something, or it's just heart failure on its own. So when there's an increase in the pressure in the right heart, less blood will come back from the body, so then we'll have right heart failure. So literally the definition of right heart failure is increase in pressure in the right side of the heart. Basically failing of the blood to come back. Okay.
Administration of a drug that decreases the diameter of arterioles in a muscle bed, in the muscle bed of an experimental animal. Which of the following sets of physiological changes would be expected to occur in response to the decrease in diameter? A decrease in diameter also means vasoconstriction. So what would happen? Yeah, good. Mashallah, you guys are right. It is E. A decrease in diameter will mean a decrease in blood flow that can flow through that artery. Blood flow is also vascular conductance, so they're both going to be low, and capillary filtration will be low.
MashaAllah, good. This is literally the exact opposite of the question we had a few minutes ago. So it's good. You guys learned from your mistake. MashaAllah, good. Alhamdulillah. Okay. What often occurs during decompensated heart failure? So I'll make this easier for you. Let's say left heart failure. If A said pulmonary hypertension, then it would be right. Yes, it would be B. Be confident, guys. No need for question mark. Even if you're wrong, it's okay. So during decompensated heart failure, the cardiac output would decrease, right? So it's because of the weakness of the heart and the edema on the cardiac muscles, right? The cardiac muscles. So the pressure in the pulmonary capillary system would increase. That's because of the congestion, the failure of the left heart to pump blood, right? So the blood from the lungs will fail to go back to the heart, to the left heart. Tamam? So there will be an increase in mean pulmonary filling pressure. MPFP. Okay? Usually when they say heart failure, they mean left heart failure. Unless they mean right heart failure, then they will say right heart failure. Okay? So when we say heart failure, we usually talk about left. When they say right heart, then they mean right heart. That's it. Okay? Tamam. Is this clear, guys?
The tendency for turbulent flow is greatest in which of the following?
Okay, good. MashaAllah.
Okay, mashallah, amazing. Yes, it is small arterioles.
The aorta, you mean?
No. The answer here is not correct on my slide.
It's the
Okay.
largest
Yeah.
portion.
Yeah. It is D. On my slide, it's C. So yeah, it is D.
The explanation, wait.
Did I type the answer wrong? Just wait.
Yeah, you probably put the answer wrong. It is C. It's
So I
C.
answered in my head right, but I put it on my slide wrong.
It's C. I didn't even
How?
think about
Okay.
it. I just saw the yeah, so arterioles are the pressure vessels, right? So there's a higher chance for turbulence as it's the highest pressure.
Yeah.
I don't know why there's arterioles and small arterioles and I don't know what's the difference, but so just put the smallest thing possible that's arterial.
Yeah, the smallest thing possible because it's the closest to the junction between the
Hmm.
arterioles and the venules.
That's arterial. If they put venules, it's wrong. Okay, the smallest thing possible, that's arterial. How do we get the answer you mean for this question? Okay. So the answer is C, guys. Okay, this is C. We'll fix this inshallah before we send the PowerPoint. So this is slide 99. Okay. Okay, which of the following often occurs in decompensated heart failure? Same question, different answer. I'll be surprised if you guys get this right. That'll make you overthink now. Don't overthink. Whatever you know is right.
B.
Good thinking, but try again. Okay, wait. I have a question. Do you guys know what orthopnea means? You guys didn't take orthopnea? How did they give you heart failure without orthopnea? Okay, so basically orthopnea is difficulty breathing when lying down. Okay, so that's because of the pulmonary hypertension, the pulmonary edema from the heart failure. Okay, so the answer is D. I apologize. I didn't. I thought you guys would know what orthopnea is. So just keep this in mind. Okay, it's basically difficulty breathing when lying down, and it's very, 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 very common in heart failure. Okay, or decompensated heart failure to be more specific.
Okay.
Wait. Would be correct if they say increased mean systemic filling pressure? Mean systemic filling pressure. Yes, there would be a higher pressure. It would be right, in my opinion. If you think it's otherwise, please let me know. But I think it would be right. Okay.
Okay. Which of the following vasoactive agents is usually the most important controller of coronary blood flow? Most.
A.
Yes, you guys are right. Inshallah, it is A. This is just recall.
Good. Yeah. And that is very important. It's usually the lowest for me. Okay. In which type of shock does cardiac output often increase? When will we have a lot of cardiac output?
A.
Unfortunately, no, it's not A. And no, it's not D. Actually, you guys took, yes, you guys took septic shock, right? I saw it in the slides. Yeah, it would be septic shock. So in septic shock, the cardiac output increases because of the vasodilation in the affected tissues, and there's a high metabolic rate, right? Because there's toxins and stuff like that. It's basically an allergic reaction. It's not exactly an allergic reaction. That would be anaphylactic, right? But it's septic. And it would cause vasodilation on other parts of the body, okay? And in the other ones, it would decrease. Just keep that in mind. Cardiac output increases in septic, okay?
I think we had this question before, right? A decrease in which of the following tends to increase pulse pressure?
Will I skip it? Yeah, we did have this
Yeah,
question,
if everyone understands this concept, we can skip it because we had a
Okay.
very similar question before.
Okay, let's see the answers. Guys? Okay, yeah, خلاص they know it.
Yeah, it's compliance.
Okay, which of the following is I made this question myself. Which of the following is the control center in the medulla oblongata of the brainstem responsible for restoring blood pressure?
NTS.
Huh? NTS. That's the only one you took, so just solve that. These are all nuclei that you're going to take in neuro, inshallah. These are some of them. Okay, yeah, it is NTS, nucleus tractus solitarius. Would you guys like me to explain this? The negative feedback for blood pressure? Or is this clear for you guys? Because a lot of people wanted us to explain the integrated control of the CVS concepts. Okay, I guess we'll move on.
Okay. At the onset of exercise, which of the following normally occur? I explained this, I guess, in the middle.
Yep. Yeah, you
beginning.
finished one of the questions, yeah.
Yeah. Remember when I told you why do you have to move in a long flight?
Long flight. There you
Yes. B. Increased venous constriction. Does everyone understand this question? Okay, good. That helps. Okay.
go. Tamam. Which of the following is a location for high pressure baroreceptors? This is from the slides.
Okay.
Tamam. What about the low pressure baroreceptors? Wait. Which of the following? Oh no, wait, that's Baan's question. Khas, don't explain the the low pressure. There's a question for it. Yeah, okay. So these are the high pressure baroreceptors: carotid sinus, aortic arch, and the renal efferent arteriole or the kidneys. Okay, Baan's question.
Which of the following is normally associated with an increased venous return of blood to the heart?
E.
Did you say E?
Yes.
Yes, it is E. You guys are correct. Increased blood volume will, it's kind of obvious, but increased blood volume will increase the amount of blood that goes back to the heart.
Okay, which of the following is a low pressure baroreceptor location? I put many options because I wanted to make sure that you guys know all of them. A, B, and C, which is also G. Yes. Okay, good.
But what would the right atrium release upon a change in pressure, in blood pressure?
Oh,
There's a peptide that it releases. And you guys, I think they took it.
they should have. We took it in first year.
Yeah.
And the other one is from the ventricle.
Yeah. But
Can I tell
I
you?
remember only taking the one in the atria.
No, I remember we took both because I remember it doesn't make sense.
Wallah?
Yeah.
So the peptide that is released by the right atrium when there is a change in BP is ANP,
ANP.
arterial pressure,
Atrial natriuretic peptide.
yeah, natriuretic peptide.
Yes. So it stimulates natriuresis.
Yes.
And the one from the ventricles is called BNP, brain natriuretic peptide. Didn't take this, so okay, just forget about it then.
Okay.
Don't worry about it. This is AJ physiology stuff. Don't worry about it. So yeah, G is the right answer. AJR, yeah. We just call him AJ. Would you guys like me to explain this? Because again, you guys wanted me to explain the integrated control of the CVS again properly. Would you like me to explain this? I put this slide here in case someone wants me to explain. Guys, come on. Yes, no.
Explain it for the recording, just in case someone wants it explained.
Okay, good. So baroreceptors are sensitive to increases and decreases in stretch of the blood vessel walls, right? So if we have an increase in cardiac output, there will be an increase in the stretch of the baroreceptors. There's more blood, the baroreceptors will get stimulated more often because there's more pressure on the vessel wall, right? This will increase the signal to the nucleus tractus solitarius, and the regulation of the organs to reduce blood volume and pressure will happen, okay? If there is low pressure, the baroreceptors will be less stimulated. So if they will be less stimulated, then they'll go, okay, there's no blood, there's no volume. So it will increase venous return, and it will increase stretch of the low pressure baroreceptors, and it will increase the afferent signal to the nucleus tractus solitarius, and regulation of effector organs to reduce blood pressure, volume stuff, whatever. Okay? So high pressure baroreceptors monitor cardiac output, and low pressure baroreceptors monitor venous return. Okay? High pressure, cardiac output, low pressure, venous return. Less blood returning, it will go something's wrong, we're losing blood, we're bleeding, so it will venoconstrict, and etc. If there is a high pressure, there's too much blood, it will which will obviously be monitored by cardiac output, then it will tell the heart to, hey, relax. Okay? Yes, okay.
Okay. A 30-year-old male is resting and his sympathetic output increases to maximal values. Which of the following sets of changes would be expected in response to this increased sympathetic output? Remember, sympathetic.
Resistance to venous return. So it's
Could it be
venoconstriction, I guess. Say that again.
G?
Resistance to venous return, I guess, is مثلا high pressure in the right heart, مثلا, or vasodilation, stuff like that.
Yeah. Why would resistance to venous return be low in sympathetic output? It's A. Everything is high.
What?
So during increase in sympathetic output to maximal values, several changes occur. Okay? So first, the mean systemic filling pressure increases like a lot, okay? But at the same time, the resistance to venous return also increases. The venous return increases also because of the vasoconstriction from the sympathetic outflow, okay? There's also a formula. I don't know if you guys took the formula. It's venous return that equals mean systemic filling pressure minus right atrial pressure over the resistance to venous return. I don't know if you guys took this formula. So during maximal sympathetic output, the increase in systemic filling pressure is greater than the increase in resistance to venous return. Therefore, the formula is a numerator that has much greater increase than the dominator. This results in an increase in the venous return. So the sympathetic outflow will vasoconstrict veins, and that will increase venous return way more than the resistance to venous return. So the pressure in the right atria is high due to the sympathetic outflow, but also the venous return is high due to the vasoconstriction. And the increase in venous return is way higher than the resistance to venous return. That's why يعني the result in the end is more blood going back to the heart.
Yeah.
Is that understood by everyone?
So they both increase, just that the numerator has a greater increase than the
I'll
denominator.
re-explain. I'll re-explain.
Maybe if they see the formula, it'll be easier.
I have a
So,
formula in
yeah.
words, not in
Mean systemic filling pressure, right arterial pressure, resistance to venous return. Okay.
mean systemic filling pressure minus right atrial pressure. Okay, this is the what do you call it? Dominator or numerator?
Numerator, and
Numerator.
the other one is
Okay,
denominator.
Denominator, okay, is resistance to venous return. So the mean systemic filling pressure and the right atrial pressure are high, or very high, and the resistance to venous return is, high, but not that much. So
read
the
the last
numerator
sentence.
is higher than the denominator, so that's why the sympathetic outflow and it constricting the venous the veins will increase venous return more than the increase in resistance to venous return. Like the heart is resisting this increase in venous return, but the sympathetic outflow is way too hard. Like it doesn't care if the heart is resisting.
Mhm.
It's stronger. It overcomes this resistance.
This is a very difficult question.
Mhm.
If you guys didn't take this formula, then don't worry, okay? Yes. You're right, Sad. The numerator increases more than the denominator, or the top increases more than the bottom. So it's a bigger number. Tamam.
Okay, good.
Okay, if mean arterial pressure increases, what happens to TPR? Will it decrease or increase? Can someone answer? Saad. Yasser.
What's your best guess?
Increases. Okay, no, I'm sorry. Actually, it decreases. This is from the slide. So if mean arterial pressure increases, okay, the TPR would decrease because there's more pressure in the arteries. So there's a lot of blood that's flowing through the arteries. So it will vasodilate, right? So the total peripheral resistance should decrease. So this is what happens to it. Okay. Okay, what about the activity in the carotid sinus efferents? So if the mean arterial pressure increases, what happens to carotid sinus? It would increase, right? So yes, sir, you're right in these first two. Okay, what about the circulating levels of epinephrine? So there's already a high pressure. Will we need to increase the pressure further? No, right? So we'll have to decrease. Yes. Okay, that's good. So decrease, increase, decrease. There's many, okay, of these. There's a slide that has like 10 of these. I just brought the 3 that I think are most relevant. Okay. But obviously, I suggest you go back to that slide.
Okay. Which of the following normally cause the cardiac output curve to shift to the left along the right atrial pressure axis? This is a cardiac function curve along with the venous return cardiac output and cardiac function. I'll show you the diagram in a bit. So which of the following will cause cardiac output to shift to the left? So cardiac output increase. Well, what can increase the cardiac output? You were saying something, Yousef?
B. B.
Yes. Actually,
No,
think again about that.
Good thinking, but try again.
Would severe cardiac tamponade, does everyone know what tamponade is?
I was just gonna ask that.
Yes, it's excess pericardial fluid.
Yes.
Okay, but
So an
may
excess in pericardial fluid will increase the pressure on the heart. It's like pushing on the heart like that. It's compressing it.
Mhm.
So severe cardiac tamponade is not going to increase cardiac output. It's actually the opposite. It's going to decrease it due to the increase in pressure on the heart. Okay? So think again.
Hint, you weren't far off. In terms of the options, I mean.
Would it be A?
Surgically opening the chest, it makes the cardiac output shift to the right. It actually decreases the cardiac output. It's not going to increase it.
C?
C? Yes, it is C.
It's Valsalva, guys. Remember, increase intrathoracic pressure.
Yes,
Compliant
Munib, you're
veins.
right. Yeah, it is
C.
C. Breathing against the negative pressure.
Okay, so they could have just said Valsalva, but they like to put spices on
Play
the
with
options,
words.
right? Yeah.
Can you go 2 slides next? I have the diagram.
Okay. Here you go.
Yes. So this diagram is really important in CVP, guys. So the y-axis over here is cardiac output and venous return. They put it on the same side because in normal situations, in ideal situations, cardiac output must equal venous return. If it doesn't, alterations in this graph will happen. All right? So this red line over here is vascular function, i.e. cardiac output, i.e. venous return. This purple or blue curve over here is cardiac function, i.e. contractility. Okay? So I think I have another graph after this. Can you please switch to it, Yousef?
Oh, sorry. Nah.
Yes, this is from Dr. Simon's lecture. Please memorize this. Also understand it very, very, very well. Because sometimes you'll forget what this means, you forget what this line is, you'll forget what this line is. Just understand how it works. So as I said, these lines are concerned with cardiac output and venous return. So any shift in these lines, whether it was upward or downward, is a change in cardiac output and venous return. These lines over here, okay, whether it was a shift over here or to here, and in this case, this is a shift to the left, this is a shift to the right. Any change in these lines is a change in contractility. So a shift to the left is, like the question before, is an increase in contractility. The green line, this green line, is an increase in contractility. The red line over here is a decrease in contractility, which is a shift to the right, as you can see. Right, left. Okay, so this is the easy part. Now the venous return and cardiac output. These 3 lines, the dark green one, this is the blue one, which is the normal, and this is the dark red one. These 3 lines, they end at the same mean arterial pressure. They have the same mean arterial pressure. And these lines, whether it was a shift upward or a shift downward, these are changes in arteriolar tone. So a decrease in arteriolar tone will lead to this green line. An increase in arteriolar tone would lead to this red line. Okay, this red line is below the normal line. That means an increase in venous return and cardiac output. Why would venous return and cardiac output decrease with increase in arterial tone? Because imagine it like this. The arteries, an increase in their tone means vasoconstriction. The arteries are vasoconstricting. They're not allowing blood to go from the arterial side to the venous side in order to go back to the blood. They're constricting. They're holding the blood in their vicinity. So an increase in arterial tone means a decrease in the amount of blood that goes to the heart, i.e. venous return. That's why the dark line over here is below the normal line. a decrease in venous return can be caused by an increase in arterial tone. Also, a decrease in venous return can also be caused by an increase in venous compliance. What does that mean? It means that the veins are vasodilating. If the veins vasodilate above a certain point, the blood won't be able to go back to the blood. The blood won't be able to go back to the heart. The blood is pooling in the veins. Like the veins need to pump the blood against the gravity to go back to the heart. If the veins vasodilate to above a certain point, like excessively, the blood will pool. That's why an increase in venous compliance will decrease venous return. Also a decrease in volume, which makes sense. Yani. If you don't have blood, not a lot of blood will go back to the heart, right? It makes sense.
Yes.
So we explained the arterial tone and why it ends in the same mean arterial pressure, and an increase in venous compliance and decrease in volume. Same thing for this green line over here. An increase in volume, an increase in blood, that means more blood will go back to the heart. A decrease in venous compliance means constriction, vasoconstriction of veins. That means, again, as I explained before, pumping the veins and allowing the blood, more blood to go back to the heart. That's why this line over here is above the normal line. This is the normal line. This is the line that we're talking about. And this is, and what I just explained, an increase in venous compliance, the blood is pooling in the veins. That's why it is way below the normal line.
Mhm.
Does everyone understand?
Thank
Does
you very
everyone
much, Dr.
understand
Baan.
this graph? If you don't, I'll re-explain. This is really important. Because the doctor can ask you about any of these points, A, B, C, D,
Alfiya.
E, up until J. They can ask you about anything over here.
Is this clear, guys? Very clear. Thank you, Dr. Baan.
Alhamdulillah.
يعطيك العافية.
ويعافيك.
Okay. Can we move on?
Yeah, if everyone understands, I think we're good.
Okay, so we have a few questions left. Just bear with us. كده shake, shake. Okay, what happens when the when we electrically stimulate the carotid sinus nerve? صح, we'll get hypotension. Why? This is from the slide, by the way. So it will mimic an increase in baroreceptor discharge, right? So it's kind of like telling the body there's too much blood. So it will reflex bradycardia and which will lead to hypotension, right? So there will be less sympathetic and more parasympathetic discharge. Okay? حرفيا من السلايد. And there are a lot of notes in the slide legends, by the way. Okay. Do you guys want me to explain this? I'll explain this for the recording, like you said, man. Okay, overview of blood pressure control. Okay, Bismillah ar-Rahman ar-Rahim. First of all, we have a decrease in mean arterial pressure. This is the primary stimulus. With a decrease in MAP, we'll have a decrease in baroreceptor stretch, which means a decrease to nucleus tractus solitarius, which means decreased activity to NTS, right? If there's a decreased activity to NTS, there are two possible ways, pathways, either an increase in vasomotor activity or a decrease in cardio-inhibitory activity. So if there is an increase in vasomotor activity, we'll stimulate the sympathetic nervous system, which will increase TPR and contractility and heart rate. An increase in TPR will cause an increase in mean arterial pressure, which will solve this problem. An increase in contractility will increase stroke volume, which will increase the cardiac output, which will increase the mean arterial pressure, solving this problem. An increase in heart rate will increase the cardiac output, which will increase the mean arterial pressure, solving this problem. Now let's come to the cardio-inhibitory activity, decrease in cardio-inhibitory activity. So if we decrease the peripheral nerve, parasympathetic nervous system, we will have an increase in heart rate because we decreased parasympathetic. Increase in heart rate will cause an increase in cardiac output, which will cause an increase in mean arterial pressure, solving our problem. Okay, I think this is simple enough. Does anyone have a question? It's okay if it's not simple, yani. It took me a lot to understand this in first year and get it down. Okay, I'll assume that this is fine, and inshallah you guys can go back to the recording and listen to the explanation. Okay, Dr. Baan.
Which of the following will elevate the plateau of cardiac output curve? Let me just draw a curve over here. This part is a plateau. What can increase the plateau? Okay, let me just, okay. So,
would it be E?
yes, it is E.
I know
Yeah.
you're increasing contractility.
Yes,
Yeah,
good, good.
good.
So
Inshallah.
this is the normal curve, and an increase in plateau, it just means a shift up.
Longer.
Yeah, it just means a shift up. They try to confuse you, but this is, in simple words, this is what it means.
Sorry, I have to go for 1 second.
So an increase in plateau means a shift up. Okay, and an increase, you remember the graph that we discussed? The cardiac function would go up when there is an increase in contractility, as Yousef said, mashallah. So it is E.
Okay, I'm back. Okay, are we ready to move on?
Yes.
Okay, so E, like Dr. Baan said. Okay, what's the function of angiotensin II and where does it apply its effects? So I didn't really care too much about angiotensin because you guys are going to take it in renal in more detail, inshallah. But there's a whole slide about it, so I'll at least make sure you guys know the function of angiotensin.
Now, although Dr. Simon said do not pay too much attention to it because he said that we're going to take more of this in renal, so he just skimmed it a bit, or that's from what I remember.
Okay, but you should know the function of angiotensin.
Would
It's only
it
one
be
thing.
It's A or B عشان it's 81 receptors.
81 is correct, but it's a vasoconstrictor, okay?
تمام.
Tamam? Make sure you get tell wallahi they can ask you a question. Or someone has the RAS system activated. What would be the most likely thing? And the method and the answer would be increase in TPR. Why? Because it's vasoconstriction. Okay, so keep this in mind. Just know angiotensin, vasoconstriction. I thought of a way to remember it, but I guess you just have to remember it as is. Okay, this is the slide. Angiotensin constricts at 81, stimulates aldosterone, so sodium and water retention, and stimulates antidiuretic, which stops urination, so you'll keep fluid, retain fluid. Okay.
Which of the following normally cause the cardiac output curve to shift to the right along with right atrial pressure? Shift to the right. Remember what we just explained? This is the curve. We'll shift to the right.
Is it D?
Yes, it is D. Remember what I just explained? I said when surgically opening the chest will decrease cardiac output and decrease contractility. Yes. Does everyone understand this?
Yes.
Okay, good. Okay, so how does chronic hypertension work? I saw this in your slides, so I thought it'd be nice to this question. Okay, someone already answered. Sad. Yeah. Yes, it's A. Yeah. So baroreceptors adapt to chronically elevated blood pressure and no longer signal the brain that the pressure is elevated. Okay, so it just becomes desensitized, basically. And this is the slide. So high pressure bioreceptors are not effective in long-term blood pressure control, okay?
Yeah. 22-year-old man enters the hospital emergency room after severing a major artery in a motorcycle accident. Is estimated that he has lost approximately 700 milliliters of blood. His blood pressure is 90/55. Which of the following sets of changes would you expect in response to hemorrhage in this man? Yes, you guys are correct. It is A. You would expect an increase in heart rate due to the hemorrhage. The heart is trying to compensate. Sympathetic nerve activity and total peripheral resistance would increase due to the sympathetic nerve activity being increased. I hope that's clear.
Good. Good.
Okay. Excess production of which of the following would most likely result in chronic hypertension? Yousef just explained chronic hypertension.
Nitric oxide.
Why?
ولا C.
Yes, you guys are right. It is C. The only option over here that is a vasoconstrictor is angiotensin 2. Nitric oxide vasodilates.
Yeah, so that's why I mentioned angiotensin 2 as well. It's a vasoconstrictor. Prostacyclin, ANP, and nitric oxides are all vasodilators, okay?
Mhm. Okay. A balloon catheter is advanced from the superior vena cava into the heart and inflated to increase arterial or atrial pressure by 5 millimeters mercury. An increase in which of the following would be expected to occur in response to the elevated atrial pressure? Remember when we mentioned this and you guys said we didn't take it? Yes, it is A. Atrial natriuretic peptide. A change in pressure would, blood pressure would trigger the atria to release this, ANP. Is this clear?
And if it was the ventricle, BNP. It's called the
Yes.
brain natriuretic peptide, but it's from the ventricle. Don't ask me why.
It's called brain?
Yeah.
Memorize
Believe
it
it or
as
not.
BNP. Just memorize it BNP. خلاص. Okay. An increase in shear stress in a blood vessel results in which of the following changes?
Last question, by the way.
This is mentioned in your lecture. Exact same wording. Yes, it is C. Increased nitric oxide release. Shear press or mechanical stress on the endothelial cells would trigger nitric oxide formation or synthesis. Is that clear?
If you guys didn't notice, we kind of ran out of questions, so we had to make our own. Okay, good. Thank you, guys. But don't leave. Wait. We need you to scan this. Wait. Please scan this code.
Yes, please scan it.
Give us some feedback. You're welcome. Of course.
Thank you, guys.
Happy to help.
I hope you benefited from this. I know we took too long, but still, needed.
Yeah,
The topics are really
yes.
heavy, and it's weird to us that Dr. Simon is giving you the lectures and he's including a lot of information, so we tried our best to cover everything. سامحونا على القصور I really hope we did cover everything, at least the high yield topics. And Dr. Simon's questions are most likely going to be easy. They were easy in EndoRepro. We only had him for EndoRepro, so.
Yeah, we didn't have him for CVP. But inshallah, his questions are usually straightforward and easy.